So welcome to MSOT Scholar Day. My name is Shinwe Augustus. I am the Administrative Assistant to, yes, Shinwe Augustus Burrows. Thank you for remembering that. I am the Administrative Assistant to the Dean of Graduate Studies, and I have the pleasure of guiding you guys through this inspiring event today. Today, we recognize and celebrate you, our MSOT students, for your dedication, your resilience, and your academic accomplishments. Just to get today started, we would like to invite Mr. Michael Walker, our third-year MSOT student, to lead us out in our opening prayer.
All right, good morning, everyone. These are many of the mercies we ask in your holy name. Amen.
Thank you so much. This time, I would like to invite Dr. Reef, our Director of MSOT, to share her opening remarks.
Good morning, everyone. Thank you all for joining us on the 5th Occupational Therapy Scholar Day, hosted by us, the MSOT program here at USC. I would like to extend a warm welcome to the Provost who's here with us, other administrators, faculty, staff, advisors, and our dedicated OT students, along with the family members, friends, well-wishers, and any special invited guests here today. We are honored to have you all with us. A special acknowledgement goes out to our keynote speaker for today, Dr. Keisha Lewis, whose presentation on health will be invaluable insight to inform our practice and guide and impact decision-making in healthcare. To our MSOT program, the MSOT program at USC is committed to nurturing and equipping future occupational therapists. Today, we celebrate the hard work, dedication, and scholarly achievements of our students today. It is also a recognition of their contribution to the growing body of occupational therapy knowledge, especially within the Caribbean context. We extend a heartfelt gratitude to our research lecturers, Dr. Deidrean Silly, our research advisors, Dr. Cogobelt and Dr. Campbell George, practicing occupational therapists, and all participants who supported our students during their research journey. As we move through today's program, I encourage everyone, whether joining us online or in person, to engage fully, ask questions, share feedback, and explore diverse and innovative topics our students have prepared. Thank you all again for being here, and let's join this procedure. Thank you, guys.
Thank you so much, Dr. Reef. So at this time, we would like to bring the official greeting from the university, and we would like to welcome our Provost, Dr. Len Archer.
Good morning, all. Thank you very much for the invitation, and thank you for attending, all of those of you who are here and all of those who are also online. First, I'd like to thank Dr. Kimara Reef, who is our acting director of the MSOT program, for her leadership and the guidance in this program, which has so much potential. And I know this is one of those opportunities we have of sharing what a good work you're doing over there. Thank you, Dr. Reeve, and your team. Shakila John Marshall. I have to remember that last name. Thank you very much. Yes, and all the other individuals who play an important role in the program, or adjunct lecturers, and other lovers of the program. I noticed some familiar names here, like Dr. Patricia Coker Bolt, who has been a dedicated and loyal part of this program for several years, coming here as a Fulbright scholar and remaining engaged. We really appreciate it for her. I don't know if she's online. If she is, I hope you hear what I say. Thank you very, very much. And all the others who are so familiar. I know I can call a lot of names, but I want you to understand how appreciative we are as a university for what you do. Occupational therapy is one of those budding minor programs sort of in Trinidad and Tobago. It doesn't carry all the prestige for many people that some other professions have. But we know it has become such a vital part of the development of our society, development of our children, development of adults who are in need of the occupational therapy services. You know, when I was a child growing up, you didn't hear anything about occupational therapy. It wasn't even a career. But we now know that there's so many people in this space that require the needs. And having worked with an occupational therapy department for several years at another institution, I grew to understand how important this profession is, the role that they play, the way they prepare people to get back to work, and the way they guide children who have a variety of developmental issues. And so for those of you who are here today, what you hear is really some very good academic work by our students. But I also want you to spread the word. I want you to spread the word. I want you to be recruiters for what is a critical need in our society for a lot of people. You won't recognize it until maybe it gets close to you. Not just being a part of an academic program, but I have two grandkids who are on the spectrum, and I've watched the therapy they've had since they were a year or two old, and see the dramatic changes that occupational therapy, physical therapy, and speech therapy has done for them. And we have too many people in our society who continue to suffer through their lives because we don't understand and know enough about what occupational therapy can do. So thank you very much. Again, a warm welcome to all of you who are here, and I look forward to the presentations by our wonderful students. And I have to tell you, we do have a wonderful program here, to none. So thank you very much.
Thank you so much, Dr. Archer, for your kind words. As we know, he is the provost of our institution, and without his support behind all of our academic achievements and all of our academic goals, we would not have the occupational therapy program here today. So we really appreciate the support that we get. At this time, I would like to introduce Dr. Ronnie Roberts. He is our program coordinator in the School of Graduate Studies, and at this time, he will introduce our keynote speaker.
Good morning, one and all. Our keynote speaker for the 5th Occupational Therapy Research Scholars Day is Dr. Keisha Lewis. Welcome, Dr. Lewis. Dr. Keisha Lewis completed an Associate of Science degree in Psychiatric Nursing from Nehurst in 2000. She also possesses a Bachelor of Science degree in Mental Health Studies and a Master of Science degree in Leadership and Management in Public Services from the University of Hertfordshire in the UK. In 2017, Dr. Lewis completed the PAHO WHO Advanced Course on Innovation and Implementation of Mental Health Policies and Care Delivery. In 2014, she graduated with a Doctor of Philosophy in Health Administration from the University of Trinidad and Tobago. Dr. Lewis is registered with the Nursing Council of Trinidad and Tobago, as well as the Nursing and Midwifery Council in the UK. Over the past 25 years, she has worked in various clinical and management settings. Dr. Lewis is currently employed in the position of General Manager, Mental Health Services at the Northwest Regional Health Authority, where she leads, manages, and provides oversight of the development, delivery, and monitoring of mental health services. Prior to joining the NWRHA, she held the position of team lead of a 24-hour crisis assessment and treatment team in the UK. Dr. Lewis contributes to service development through the implementation of mental health policies and the participation in digital transformation projects in mental health. She's also an adjunct lecturer at the University of the Southern Caribbean and COSTAT. Dr. Lewis is the Mental Health and Psychosocial Support Technical Working Group, the Country Action Group for Mental Health Initiatives, and the Caribbean Coalition for the Decriminalization of Suicide. She is currently involved in mental health advocacy and promotion. In her free time, yes, apparently she has free time. Dr. Lewis enjoys outdoor activities with her husband and her 2 children. And so, perhaps we can expect to hear from her stories that she practiced. At this time, it's my pleasure to invite to the podium Dr. Keisha Lewis to speak with us.
Podium over there because I'll block the other. Yeah. Oh. Good morning, all. Thank you so much for that introduction. So before I start, can you pull up the presentation? So I'm going to share a little bit with you about my research journey. I'm going to take you through the idea from concept to completion, right? 15 minutes, 20 minutes. So when I got this call to do this, I accepted, because you will soon come to realize that you will take every opportunity you can to share your research. You will grow into that. But then I realized it was the Masters in OT program. And as some of you who came from Northwest would know, I managed the occupational therapist, right? So I'm sure I will be seeing some of you in the future. So while the presentation is being pulled up, you want it back? You got it? So we have quite a large occupational therapy department at Northwest. We have one occupational therapy, three occupational therapists, one, and a number of occupational therapy aides. So in your career where you want to push forward, okay? And in joining this program, some of you would experience that. So continuing professional development is one of those ways in which you can do that through education, of course. But we know that various factors need to be taken into consideration. It has to be the right time, professionally, personally, financially, etc. So for me, I had the idea that I wanted to continue doing research after the master's. And when some of you decide to go on to your PhDs, you'll understand. So I thought about it for a number of years, for about 2 years actually. Then I decided, you know what, it's the right time, I'm going to take the plunge and I'm going to do it. Go ahead. Next. So the spark, right? This is an idea you have that you think you want to explore. So looking at a topic, of course, that has future potential, that you have some experience about, that you're interested in, but also, and sometimes we don't like to think about this, but you want a topic that sounds good, right? You just don't want any old topic. Okay, go ahead. So I had a couple of ideas that I wanted to do. I wanted to first do some research around decentralization of mental health services. We've heard that word before. I wanted to look also at the economic impact of mental illness in Trinidad and Tobago. Like, how much does mental illness really cost the country, right? Go on. There were good buzzwords in there. There was no previous research done around the economic impact of mental illness. I started draft proposals, but then I had academic advisement, right? Go on. And I realized I had to leave those two topics behind, okay? Because, go back to the next one. While decentralization sounded like a good idea, the fact of the matter was that there is a national plan for decentralization. It needs to happen, not only locally, regionally, and internationally. That is what needs to happen. So there was nothing new that could have been added. My supervisor told me up front, while the economic impact sounds good, I'm not an economist, right? So at PhD level, I would not have the aptitude to do something like that, right? So then I had to go back and look at where my interest lies. Go ahead. So these are some of the things that made me choose the topic I choose. It had future potential. I had work experience about it. It's something I was interested in. It's something that sounded really good. You'll hear it in a minute. And most importantly, from where I sat in my role, this was a topic that was a burning issue and presented a day-to-day challenge for me. Okay? When I had the thought of doing research, you know, one of three things, you know, my advisor said to me, you have to be, you know, healthy enough to conduct research. You have to have the financial means, of course, but most importantly, it needs to be a topic that you are passionate about, because you are going to get fed up of it. You're going to not want to see it. You're going to not want to hear about it.
Go ahead. So I had the idea of doing something around mental illness and homelessness. Go ahead. So I had to start to look at terms, you know, what was meant by mental health, what was meant by mental illness, what it means to become homeless. Now, we all have the perception, think about walking down Frederick Street. We all have the perception that everybody who is homeless on the streets is mentally ill, right? This is not the case, right? So there had been no research in Trinidad to determine if mental illness is really a causative factor, a cause or consequence of homelessness, right? And it's like a chicken and an egg story, you know, which comes first? Go ahead. So I started with reviewing the literature, of course. I looked at key phrases and searched mental illness, mental health, homelessness, homeless persons, mental health services. Mainly studies from the US, Australia, Canada, Europe. But these were some of the gaps I found, okay? There was no research relevant to our local context. Mental illness as a factor in homelessness had not been explored. And I wanted to understand the lived experiences of the mentally ill person. So the reason I put this here, topic versus actual name of the research, in the end, this was the title of my research, okay? The role of mental illness in contributing to homelessness in the Trinidad and Tobago context. And the reason I said that is because it took me a good year to pin down a name. And I remember my supervisor saying to me, look, we need to pin down a name, we need to pin down a name. But that became clearer to me halfway, three-quarter way through the literature review, because the more you read, the more you understood. And really, it is only after that literature review I understood myself, my position, and what I really wanted to study, right? Because there's a bi-directional relationship between mental illness and homelessness. So mental illness can be a cause or a consequence of homelessness, and vice versa. So I determined that I wanted to study the relationship between mental illness as a causative factor for homelessness, right? In other words, I didn't want to go down Frederick Street and engage with mentally ill homeless people, right? Not really, I know. But the reason I'm telling you this is because you choose research from the position at where you are. So where you are going to be able to have some influence and some effect in getting the recommendations through. Okay, so it becomes something that's reality. So my recommendations can be move all the homeless persons from the street, right? So it's from a health perspective and not a social care perspective. Now, the reason I put a theoretical framework in there is because I didn't know these things existed. I have been in the field of mental health for over 20 years, but the more you read, the more you understand. Okay, go ahead. So after about a year and following the literature review, this was the aim of my study, to understand homelessness and housing problems in Trinidad from a mental health perspective. Okay, and the objectives were to understand how homelessness is experienced, to understand the role of mental illness from the perspectives of not only the mentally ill persons themselves, but from relatives and from health and social care professionals. And of course, to understand how mental health services can better serve the chronic mentally ill and cater to a reduction in homelessness. See that third one, to understand from how mental health services, where I sit in health, can make the difference. So this is the methodology I took, an interpretivist approach, qualitative methodology, a case study, research design, sampling was purposive. Data collection was through semi-structured interviews and Of course, I saw somebody mentioned thematic analysis and the use of en vivo. Now, I never even heard that word before, en vivo, right? And I was more than happy to do data analysis manually. But of course, the opportunity presented itself. I thought, I'm doing this anyway, so let's learn something new. But I kid you not, it was a huge challenge. From YouTube to back to like about 3 screens, trying to learn this thing and apply it at the same time to do PhD analysis. That in itself was terrible. Thank goodness, at the time that was COVID, and those were the early days where you got 21 days quarantine leave. So I spent those days doing thematic analysis. So these were some themes that derived from interview transcripts. Go ahead. And really and truly, the common themes around the patients, relatives, and health and social care professionals was mental illness and was family support. Now, my discussion focused around mental illness as a vulnerability for homelessness. But of course, there are other factors that play a part. There was housing instability, the erosion of social networks, challenges with employment and education, dependence on the psychiatric hospital, and lack of support from other professional services. Go on. Some of the contribution to knowledge my study impacted was the support of investment in the psychiatric treatment of mentally ill persons who are homeless. I hope you're seeing the difference. It is the support of investment is not to provide housing for mentally ill people. It's the support of investment in the psychiatric treatment so that we get people before they end up on the street, kind of. Of course, there are limitations to any study. The mentally ill sample only comprised of inpatients, and the participant sample was relatively small, but we did achieve data saturation, okay? There were 10 inpatient interviews, 6 relatives who consented to participate, and 5 health and social care professionals. Now, before I go on to recommendations, one of the most challenging things about this was getting ethical approval, okay? Imagine asking for ethical approval to interview mentally ill inpatients of a psychiatric hospital. It was a serious back and forth, okay? My ethics application was about 20-something pages. But it was a huge celebration when the university agreed. And actually, it wasn't that, okay, let me just say it was much more difficult to get the university's approval than it was to get the Northwest approval and the Ministry of Health, okay? So the recommendations, of course, multi-sectoral collaboration. Health cannot work independently to, manage the issue of mental illness among the homeless population. And these are the different factors that needed to be considered: service delivery, policy, education, finance. And this is a breakdown of how I intended to implement some of these recommendations. And some of these things have actually been implemented already, apart from, of course, the longer term goals, right? Go on. Areas for further research, including testing whether difference in genders in the relationship between mental illness and homelessness, as participants were mostly males. So is it that mentally ill males are more vulnerable to becoming homeless than mentally ill females? That's an interesting area, I thought. And the sample size comprised mainly of patients with a diagnosis of schizophrenia, so that because of their difficulties in terms of symptom manifestation, etc., and the chronicity of schizophrenia, that may have influenced a lot to do with housing instability. Some of the anticipated impacts was improved planning in terms of mental health service provision, which I am directly responsible for. Ultimately, the aim is to reduce the number of mentally ill persons who become homeless and thereby reduce the number of mentally ill persons who are admitted to St. Anne's as no fixed abode. Now, reflexivity is important, yes? And I had to really look back at my views as a profession. And, you know, as nurses, I know we have a nurse here, we sometimes, you know, there's sometimes lots of relatives listed on the contact and we wonder why nobody's coming to see this person. So I really had to challenge my views on that. I also found that, you know, the perception of being homeless was different for a professional than what it was for the patient. For example, I had asked the patient about, you know, what it means to not have a home. And they were like, what do you mean I don't have a home? I live here in the hospital. So, you know, while we see our views as professionals, they have a different view. So they didn't even consider themselves to be homeless because this is where I live. I also had to look at, go back, my relationship with the research environment, you know, as from the role of manager to researcher, that was a bit challenging. I had to really refrain from being in a therapeutic relationship with patients and trying to, you know, get into that counseling mode and that signpost mode and that helping mode and that, okay, you know what, this is what you're having problems with. I will follow up with the social worker, right? Those are kinds of lines I had to draw. And of course, there was the emotional impact of patient stories. You know, sometimes we see patients, but their stories, we don't really know until we sit down really in depth and go through that. Now, I wanted to go through these factors as being important factors in health-related research, okay, which is what you are doing. So the development of any research agenda, of course, should be guided by national and international frameworks, okay? So in health, we follow the SDG 3, of course. Yeah, you're familiar with? Right, the Sustainable Development Goal, SDG 3 seeks to ensure well-being of all individuals by promoting healthy lifestyles and reducing mobility rates. And it specifically targets mental health concerns and NCDs. Now, the National Development Strategy, which we sometimes refer to as Vision 2030, right, is what guides us. Of course, the Ministry of Health strategic direction and whatever your organization's strategic priorities are, these are the things that combined justifies or makes a case for your research. And certainly if you go on to, you know, writing things like for proposals or for financial support or for grants, etc. These are the areas by which you pull from so that your research is in line with not only your organizational's strategic priorities, but the national priorities as well, okay? So what next? Of course, research enables you opportunities to collaborate, to supervise other research students, to teach part-time, but I want to emphasize to you, don't just leave your research there. You need to publish, okay? You really need to publish, right? I am currently in the process of publishing 1 out of 2 papers from my research. It is not an easy process, I kid you not, right? But this is where your sense of accomplishment comes. And this is where, you know, you share your research with the rest of the world, really. So publish, publish, publish. All right? Go on. Of course, I had the opportunity to graduate with some local celebrities. Right? We must have a photo up in there. Right? And I know if some of you are not participating in, there's always next year. This Thursday is the Northwest Regional Health Authority Research Day, which will be held at Hyatt. If you are not participating, you are more than welcome to attend, of course. And that's the end. I can take any questions. I want to say that the Northwest region absorbs perhaps the majority of the graduates from the Masters in OT programs, right? We have currently launched a day hospital at the Arima Rehabilitation Center as an alternative to admission and to support families as well. So Monday to Friday, you drop your mentally ill relative, but you pick them up in the evening. So it's a day hospital. And we are currently trying to find OTs to support that. So I am currently in the process of juggling between Cora, SAPTC, for there to spend 2 days up at Arima and 3 days at Cora. So it's not that the need isn't there. The new central block has a mental health ward. We have 26 beds. Occupational therapists are on the list there. I know the Eastern Regional Health Authority is in the process of setting up their services, and they have recently advertised for occupational therapists. So trust me, the opportunity is there. And in mental health, for those of you who have had rotations, it may be very frustrating, and it is painfully, success is painfully slow in this field, okay? But it is so needed, because if we are supporting a national decentralization plan to reduce reliance on a psychiatric hospital, getting people back to be reintegrated in society and to relearn the skills that they may have lost, it is a crucial, crucial function, okay? So I look forward to working with you all in the future, and I'm happy to take any questions anybody may have at this time. Yeah, no questions? Great, thank you very much. We'll get on with the presentations. Thank you very much.
Thank you so much, Dr. Lewis. Actually, we would like to keep you here. Ms. Noel, I would like to invite you. Oh.
21. So there were 21 interviews. There were 10 inpatients. Not that there were lots more potential for inpatients, but of course, there had to be a capacity assessment on the ability to give informed consent and whether you understood and whether you could effectively communicate. So like 10 out of about 18 proposed persons were able to do that. 6 relatives out of those 10 persons, the relatives of the persons were contacted. So 6 persons agreed to take part. Persons who didn't agree to take part really felt a sense of guilt. Really from even when you answer the phone and you say you're calling from St. Anne's Hospital, no, I don't want, I have no space, I have no, right? And 5 health and social care professionals took part. From St. Anne's Hospital, from the Ministry of Health, and from the Ministry of Social Development and Family Services. So there was a broad range of, you know, so in the analysis, we were able to compare different participant groups and, you know, what their experience was. Because, you know, as professionals, we tend to prescribe what we think is best for the person. But really and truly, how much does a client or a patient have a say in the planning of their own care? Very limited to none in this country, right? So it was, anyway, I said all of that to say it was 21. Right? Yes, of course, we had an inclusion criteria and an exclusion criteria. Yes, go ahead, Doc. Yeah. Yep. Yes. Yes. Mm-hmm. Yes. Um, it's not that none is. From the medical side, we sometimes struggle with the availability of drugs, especially first-line drugs in this country. So we tend to get the less first-line drugs. We have made an effort to incorporate now alternatives to medicine. So we have an art therapist, we have the psychology department, we have a music therapist, we have a dance and movement therapist. Because I'm telling you something, Doc, those young people nowadays, the last thing they want to do is take a tablet. They're coming to you and they're telling you that they want aromatherapy and they want yoga and they want. So we try our best to incorporate a more wellness model and try to move away from the medical model. Now, that's easier said than done. Huh? It's for years that we've been saying that. But we are very proud, you know, to have at least an art therapist and a music therapist. We manage 3 mental health and wellness center, child guidance services, the ARIMA rehab, and the substance abuse and treatment center. At every one of those clinics, we now have a full-time psychologist, which is really great for us. Actually, we just did interviews and we absorb a lot of the counseling psychology graduates from USC, especially now that UWI has stopped doing the clinical psychology program. I can see that becoming an issue for us in the next 5 years. But one of the challenges for mental health services is that we provide services Monday to Friday. So we don't have an out of hours service. For those of us who have worked abroad, we know that through the lifespan there are services for every age group. So there are assertive outreach services, child and adolescent services, elderly dementia services, there are 24-hour crisis services. So we're not there yet. But there is a drive to try and build up community services so that we can prevent the admission to tertiary services, the hospital. So there are various programs like the Image Gap program, I'm not sure if you're familiar with that, the Mental Health Global Action Plan program. So where we currently train primary care physicians in the health center to treat mild to moderate mental health conditions and keep them in primary care. Because we have this culture here that you go to a health center, anything mental illness, no, we don't manage that, they go to St. Anne's. So we're trying to cut that because the same drugs that are available to primary care. We have also had recent training in the management of violence risk in community, because if any community mental health program is to be successful, it is about managing risk in the community. So there's also the PMAV training. We do prevention and management of aggression and violence training, which is focused on de-escalation and teaching relatives how to engage, how to communicate, and how to de-escalate at home. Now, saying that, there are, unfortunately, 1 or 2 mentally ill persons who would have committed crimes and would have been highlighted on media. And we see this as representative of mental illness. You know, they're violent, they need to be locked away. You're never going to get better if you have a mental illness, but that is not actually true. I think somewhere in there I answered your question. I can't be sure. Yes. That is something I struggle with. In terms of reflexivity, I found that, let me give you an example. For example, when I phoned relatives and said, well, I am the GM Mental Health and from St. Anne's Hospital, I quickly had to change that and said, look, I am a student, researcher. I am engaging in this research. So that took some learning. I also found that, you know, being reflective, writing things down helped. But it took an extra effort to be able to achieve that. Because even when I went on awards to do interviews, you know, I'm there as the GM mental health. That's how people saw me. So it was, you know, a challenge presenting as a researcher rather than, you know, somebody who was in charge. Yeah. Definitely. And if you go, can you go back to the implementation of recommendation section? This is what I worked with. So take, for example, the first one, to start self-care, relapse prevention, and management groups. That is something that's directly under my control, right? Every wellness center, every psychiatric clinic has to offer some sort of program. It doesn't have to be every day. It's once a week, but each of the wellness centers now offer either a support group for families, a men's support group, a women's support group. So things like that was directly under my control. Even before I completed analysis, another one of the things that, you know, I mentioned listening to the emotional impact of patient stories. And one of the things that stood out to me was the frequency with which social workers changed. Now, from where I sit, I see the roster every month. I know people have to cover vacation leave and you have to move from one place to the next place, and that is what I'm concerned with, that you have a cover. Now, it really didn't occur to me that I have worked with you for 3 months to get an ID card appointment. When I leave now and go on cover, leave for 2 months, nothing happens with that, right? So I was able to say now in places like Cora, in places like the Arima Rehab, we have no movement of social workers, okay? We add somebody, but people need to follow through and not change so often. So that was something like that was an eye opener for me. We also, it should be somewhere in there, but we also started prevention and management of aggression and violence training for relatives and carers of mentally ill persons. So not just professionals, because these are the things that are going to help to keep people at home. And the erosion of social networks and the withdrawal of family was a huge, huge factor in housing instability, or in persons when they admitted, relatives saying, look, I'm not coming back for them, or I'm unable to cope at home. So trying to give relatives and carers the skills to kind of cope with that. But I do find that one of our huge challenges is not having out-of-hours service in mental health. That would improve things a lot, a lot, a lot. But I do lead the Policy Oversight Committee for Mental Health for Northwest Region. So currently we're working on a standard operating procedure for the management of community mental health services. Because right now people just function by memos for the last how many ever years. So we're trying to make things standardized so that across each service, the same thing happens. I still, up to this day, have to continuously tell people, you do not need a written referral to access mental health services. Stop telling people you have to go and get a referral. It is a walk-in service we provide. The fact that somebody builds up the gumption even to walk into a wellness center and say they need some help is not to be taken for granted. So we have a no referral policy. Come, quick, give me that bag.
Dr. Lewis, we want to thank you so much for your time and sharing this knowledge with us. We really appreciate everyone asking the questions and engaging you. At this time, we would like to introduce Ms. Natasha Noel as she provides you with a token of our appreciation for everything that you've provided us with today.
All right. Once again, thank you so much, Dr. Lewis. At this time, we will be blessed with beautiful music and song by Miss Mindy Felix.
Good morning, everyone. The song I'll be singing today is entitled Trust His Heart. As well, for me personally, that's a process that I have learned to do. But in research, I think that's a process you have to learn to do as well, in trusting yourself and your research that can see you through. So I'm going to be singing this song today.
All things work for our good. Though sometimes we don't see how they could. Struggles that break our hearts in two. Sometimes blinds us to the truth. Our Father knows what's best for us. His ways are not our own. So when your pathway grows dim and you just don't see him, remember you're never alone. God is too wise to be mistaken. And God is too good to be unkind. So when you don't understand, when you don't see his plan, when you can't trace his hand, trust his heart. Trust his heart. He sees the master plan, and he holds our future in his hand. So don't live as those who have no hope. All our hope is found in him. And he sees the presence clearly. And he sees the first and the last. And like a tapestry, he's weaving you and me to someday be just like him. God's too wise to be mistaken, and God is too good to be unkind. So when you don't understand, when you don't see his plan, When you can't trace his hand, trust his heart. He alone is faithful and true. He alone knows what is best for you. Oh, God is too wise to be mistaken, and God is too good to be unkind. So when you don't understand, when you don't see his plan, when you can't trace his hand, trust his heart. Don't understand when you don't see his plan. When you can't trace his hand, trust his heart. Trust his heart.
Just beautiful, guys. I'm sure while you guys went through doing your presentations and your research, you felt a lot of pressure, you felt a lot of, trials and tribulations, but you remember that trusting in God and keeping close to his words, he will guide you through. So we are here for the moments that we all came here for, our presentation time. Woohoo! Yay! Come on, celebrate. It's you we're here for. So at this time, we will have our first research presentation. It is titled The Lived Experience of Diabetic Amputees in Trinidad and Tobago. I would like you guys to give your attention to our students, Mr. Micah Walcott and Mrs. Natasha Leonie Noel.
Good morning again to everyone. So as was mentioned before, my name is Natasha Leonie Noel. I'm presenting with me today is Michael Walcott. And for our qualitative study, we investigated the lived experiences of diabetic amputees living in Trinidad and Tobago. So our outline is as followed. We'll be going through the background of our study, our literature review, the methodology for the study, our results, and finally our discussion and conclusion. So according to Hospital and colleagues, nearly 2 million people living in the US are living with limb loss. Lower limb extremity amputations are 10 times more common in people with diabetes than in persons who do not have diabetes. In the US Medicare population, the incidence of diabetic foot ulcers is about 6 per 100 individuals with diabetes per year, and the incidence of lower extremity amputation is 4 per 100 persons with diabetes per year. Lower extremity amputation in those with diabetes generally carries a yearly cost of about 30 to 60,000 US dollars and a lifetime cost of $500,000 US dollars. Next slide. So based on estimated reports by the International Diabetes Federation in Trinidad and Tobago, 12.7% of adults between ages 20 and 79 are affected by diabetes. Approximately 2,365 deaths are linked to diabetes, with 5.9% of those deaths occurring in individuals under 60 years of age. In Trinidad and Tobago, the yearly amputation rate demonstrated a progressive increase from 2010 to 2016. The average for the 7 years was 28 per 100,000 per year. Males accounted for 59% of cases, and 60% of those amputations were done above the level of the knee. The most common reason for amputation was control of sepsis in 71.5% of cases. A strong association between major amputation and prior intervention for foot-related problems was observed, as 52% of the sample had a pre-existing wound. Overall, 14.5% of all amputees were able to acquire a prosthesis. Diabetes was the most consistently associated comorbidity occurring in 91% of the studied population. Our review of the literature highlights a crucial need for research into the psychological and emotional well-being of diabetic amputees in Trinidad and Tobago. Current publications offer limited insight into how amputation affects their social roles, the effectiveness of available support, and the resulting impact of their quality of life. The purpose of this phenomenological study, therefore, was to explore the lived experiences of individuals who undergone lower limb amputation due to diabetes in Trinidad and Tobago. So our research questions were as follows. What are the lived experiences of diabetic amputees? What are some of the coping mechanisms used by diabetic amputees? And what are some of the barriers to occupational therapy interventions with diabetic amputees living in Trinidad and Tobago? So through the study, we hope to improve understanding of amputee experiences, increase occupational therapy awareness and services access, as well as the potential for policy change and better healthcare integration. And at this time, I'll hand you over to Micah.
All right, thank you. So the literature used for this study would have been from the period of 2018 to 2023. The databases used would have been PubMed, Google Scholar, and EBSCOhost. All of the articles were English articles, and the keywords used would have been OT, or occupational therapy, diabetic amputations, lived experiences, quality of life, coping and management, lower limb amputation, barriers, and facilitators. All right. So a study done by Alessa et al. 2022 highlighted the quality of life of diabetic amputees, associating amputation with lower quality of life and its significant impact on the physical and mental health of the participants. Activity restrictions having a negative impact on psychological adjustment, and prosthesis satisfaction having a positive impact, being factors affecting the quality of life. Prosthesis use was also associated with higher PCS and MCS scores. PCS being physical component summary, which reflects the physical health aspects such as mobility, pain, and ability to perform daily activities, while MCS being mental component summary, which reflects the mental health aspects including emotional well-being, social functioning, and psychological distress. This study also addressed depression, anxiety, and stress associated with diabetic amputation. It highlighted the high levels of depression and anxiety in amputees, the prosthesis influence and psychological impact caused, and the effects of quality of life and psychological distress over time. Right. A study done by Pereira et al. In 2018 at the Rehabilitation Center in North Portugal addressed the coping techniques used. It highlighted the low levels of life satisfaction, which is common among amputees. It brought to light effective coping mechanisms and addressed how coping can vary across gender, age, marital status, and even prosthetic use. Finally, it outlined the importance of personalized interventions in rehabilitation. And next, we have a study from Binesh et al. 2023, which highlighted the importance of occupational therapy. It addressed that improved blood sugar control, enhanced self-management skills, and increased confidence and daily routine performance all play a significant role in having no negative change in diabetes-related stress and depression. All right, I'll now pass you back on to my colleague to continue.
So we look at the methodology of our study. So for our study, we use a phenomenological qualitative study design. Recruitment began in January 2024 and concluded in January 2025. Flyers were distributed via social media, and we also visited a clinic to promote the study and recruitment. 9 participants were recruited from a private clinic and 1 geriatric home located in West Trinidad. Participants were 30 years and older with either unilateral or bilateral lower limb amputation secondary to diabetes in Trinidad and Tobago, and they also reside in Trinidad and Tobago. Our data collection tools included a demographic data questionnaire and a semi-structured interview guide related to adaptation, coping, and occupational therapy. A semi-structured interview guide was employed with additional probes. Interviews were conducted via Zoom platform, Google Meets, and in person. All interviews were audio recorded and transcribed, and thematic analysis using in vivo was done. Ethical considerations were addressed by attaining signed consent forms after securing approval from the USC's Institutional Review Board. Participants' confidentiality was maintained through data anonymization. And I will hand you over to Michael, who will go through the results.
Thank you. All right, so for this study, there were 5 males and 4 females representing the sample size. Participants ranged from ages 31 to 75 years old, with the most prominent age groups being 71 to 75 years, covering 22.22%, 41 to 45 years, also covering 22.22%, and 51 to 55, also covering 22.22%. The other age ranges would have been 31 to 35 years and 66 to 70 years, both representing 11.11% each. All right, the sample consisted predominantly of persons with below the knee amputation, which accounted for 88.89% of the participants, and persons with above knee amputation, which accounted for 11.11%. The ethnic makeup consisted of Afro-Trinidadians, Indo-Trinidadians, and mixed ethnicity, which all individually accounted for 33.33%. An overwhelming majority of 66.67% achieved university education, whereas 22.22% completed secondary education and 11.11% only completing primary education. In terms of geography, the majority of participants lived in South Trinidad, accounting for 55.56%, with North having 33.33% and Central having 11.11%. Next slide, please. All right, so the income levels differed as 44.44% chose not to reveal their earnings, while 22.22% reported earnings ranging from 2,500 to 5,000 monthly. Earnings of over 5,000 and pensioners, along with individuals accessing the disability grants as their primary source of income, all accounted for 11.11% individually. Right, so for the research questions that we would have had, research question number 1, what are the lived experiences of diabetic amputees? From this question, there were 4 themes that emerged, and they were adaptation to daily life, lack of accessibility, lack of understanding and empathy, and financial instability. Next question 2, we had what are some of the coping mechanisms used by diabetic amputees? From this, we derived 3 emerging themes, which would have been mental preparedness, social support, and faith and religion. And finally, what are some of the barriers to occupational therapy intervention with diabetic amputees living in Trinidad and Tobago? From this, we would have gotten the theme of lack of knowledge. All right, so adaptation to daily life. A quote from one of our participants would have said, "It took me a while because it was a wheelchair and I had to modify my facilities, room, bathroom, toilet, kitchen, bedroom to accommodate my new requirements now, which if I didn't do that, I don't know how I would have normalized myself." The key points from this would include learning new ways to perform everyday tasks, physical adaptations to home environments, and navigating external challenges and environmental barriers. Next, we have lack of accessibility. Many public spaces lack basic accessibility features such as no adapted shopping trolleys, forcing comparisons to more inclusive systems abroad and limiting daily independence. Even in regulated environments, workplaces often neglected practical needs, such as having heavy doors and inaccessible bathrooms, revealing the gaps between compliance and true usability. Critical medical services became inaccessible due to poor design. For example, having no disability parking at clinics, which worsened the health disparities and prevented timely care. These themes collectively illustrate how lack of accessibility in public spaces, workplaces, and healthcare facilities creates significant barriers for individuals with disabilities. Next, we have lack of understanding and empathy. Many disabilities are not visibly apparent, leading to ignorance and insensitivity demands. Being asked to prove that disability is present, for example, this creates unnecessary barriers and emotional strain. Individuals often feel pressure to visibly display their disability, for example, wearing shorts to show that they have a prosthetic leg, in order to access accommodations, leading to frustration and exhaustion from constant validation. Workplace biases assume people with disabilities lack capability, limiting their job opportunities. These themes collectively illustrate how lack of understanding and empathy from society creates significant barriers for individuals with disabilities, compounding their challenges that they already face. Next, we have financial instability. Amputation led to unexpected costs, loss of income, and difficulties of affording basic needs and medical care. Existing disability grants and welfare programs were often insufficient and inaccessible. Prosthetics required expensive continuous maintenance, creating long-term financial barriers. These themes collectively highlight the profound financial instability faced by individuals after amputation, exacerbated by the inadequate support system and the high cost of prosthetics and ongoing care. Next, we move on to mental preparedness or preparation. Participants highlighted the importance of a positive mindset, focusing on abilities rather than limitations. Shifting perspectives fostered mental strength and adaptability. A strong desire for autonomy drove participants to master daily tasks independently, enhancing confidence and control. And many viewed amputation as an opportunity for growth, framing obstacles as lessons. These themes collectively illustrate how mental preparation through resilience, self-care, self-efficacy, and growth mindsets play a critical role in overcoming the psychological and emotional hurdles of amputation. Next, moving on to social support. All right, so participants credited families, friends, and communities for providing comfort and belonging during recovery. Participants help with daily tasks, for example, transportation and errands, allowed participants to focus on recovery while gradually regaining autonomy. And support groups and awareness campaigns offered shared learning and solidarity. These themes collectively demonstrate the social support is multifaceted, encompassing emotional, instrumental, and peer-based assistance. And finally, we have faith and religion. Not finally, sorry. Despite hardships, participants expressed deep gratitude to God for life's blessings, from survival to unexpected support. Trusting God provided resilience against fear and uncertainty. Participants relied on prayer and belief in the divine grace to persevere, with one stating faith was a key to overcoming her fears. Sorry. Many emphasize that accepting God's plan, even in delays, miracles arrived at the right time, reinforcing their beliefs in the struggles, their beliefs that struggles had purpose. This trust fostered peace and amidst the challenges. These themes collectively highlighted how faith functioned as a multidimensional resource, cultivating gratitude, enabling resilience, and fostering trust in a higher purpose during life-altering circumstances. Right, and finally, we have lack of knowledge. Many participants expressed a complete lack of familiarity with occupational therapy, unfortunately. Even with the participants who had some knowledge of OT, there was a limited or inaccurate understanding of its scope. While his description captured some aspects of occupational therapy, it overlooked the broader focus of occupational therapy on self-care, home modifications, and adaptive strategies for daily life. This theme underscores the need for clearer communication about the comprehensive role of occupational therapy in supporting individuals with amputations. And then there was the lack of knowledge about OT. That means that many participants have now been missing out on the potential benefits of occupational therapy. All of these themes collectively highlight the need for increased awareness and education about occupational therapy among individuals with amputations, healthcare providers, and the broader community. I'll pass you back on to my colleague to continue.
Thank you. So we're going on to our discussion and conclusion. So for our discussion, Bouquet and colleagues investigated the challenges experienced by individuals with lower limb amputations due to diabetes at the Global Evangelical Hospital in Ghana's Ashanti region. Their findings mirror our own, revealing significant emotional and physical difficulties in returning to pre-amputation life, as well as financial instability. Notably, Bouquet's study emphasized a loss of connectedness, a concern initially shared by our participants that diminished after receiving prosthetics. Zhu and colleagues explored the experiences of patients with diabetic lower extremity amputation and their post-amputation wound care within a regional primary healthcare setting in Singapore. Their study focused on the concept of normality in the context of diabetic lower extremity amputation. And while their specific focus differed from ours, parallels can be drawn with our research. Factors impacting participants' sense of normality included limb loss, managing emotions like anxiety, navigating social stigma and unsupportive networks, as well as their resilience to not feeling abnormal, self-motivation, and the influence of family and social support. Next slide. A UK-based study done by Day and colleagues examined the everyday experiences, including the contrast between good and bad days of people living with lower limb amputations. While not specific to diabetes, their findings strongly emphasized the necessary adaptation to daily routines. Simple tasks like showering now required significant planning and reorganization. Our participants share this challenge, even with prosthetics. Uniquely, their study also highlighted the impact of phantom limb pain on daily life, as well as physical consequences, such as the inability to wear heels for the women and difficulties men faced in dressing smartly due to the need for mobility-friendly clothing and footwear to manage pain. So we go on to our recommendations. To address the issues highlighted, we recommend improving healthcare professional training to include a comprehensive understanding of occupational therapy in amputation rehabilitation, developing targeted education for patients and families to support pre- and post-amputation care and management, establishing community-based occupational therapy programs to aid in adapting to daily life and community activities, providing home-based occupational therapy and home modification assessments to ensure maximum independence and safety at home, and increasing financial support for occupational therapy services and prosthetics to ease financial strain. The implications for occupational therapy include the need to raise public awareness of its role in improving amputee rehabilitation and independence, advocated for enhanced accessibility policies and infrastructure, and promoting increased resource allocations for occupational therapy and overall rehabilitation process. Next slide. So while our study provided valuable insights, it had its limitations. The sample was skewed towards individuals who received prosthetics, and the overall lower limb population, was not fully expressed. Furthermore, the potential for emotional state biases existed due to the study's qualitative nature. Despite these limitations, our study offers some significant strengths. It captured real-world experiences of the challenges faced by this group. It provided a glimpse into their coping strategies and highlighted crucial service gaps, notably the lack of occupational therapy awareness, the need for improved clinical understanding, and the social impact concerning awareness and inclusions for individuals with lower limb amputations. So as we close, we will share our subjectivity statement. So as occupational therapy students and healthcare workers, we recognize our potential to inadvertently focus on functional independence and environmental barriers, potentially overlooking broader participant experiences. Our strong belief in occupational therapy's transformative impact on individuals with diabetic amputation, could also lead to interpreting data through a pre-existing lens, potentially attributing challenges to OT underutilization, even when not explicitly stated by the participants. So to mitigate this, we prioritize objectivity by engaging in thorough discussions of our interpretations after each interview. So these will be our references. And we would like to give some acknowledgements. So firstly, we gratefully acknowledge the strength to complete this program was none other through Jesus Christ. We extend sincere thanks to the USC community, especially to our research lecturer, Dr. Silly, our research advisor, Dr. Campbell George, for their invaluable guidance and patience, to the MSOT department, particularly Dr. Reef and Mrs. John Marshall. We appreciate all your prayers, support, and encouragement. To our cohort 5 family, who holds a special place for the invaluable moments shared throughout this process. And we profoundly and gratefully want to give thanks to our dear participants who allowed us to share in their experiences. This study was made possible through your willingness. And finally, we want to thank our supportive family and friends for all the encouragement they would have given us. And that brings us to the end of our presentation. So we now open the floor for questions.
All right, thank you guys so much. Do we have any questions?
So I work at a primary hospital here in So I work at a hospital, and the ward that I work on, I see quite frequently persons with lower limb amputations due to diabetes. And it sparked a question in me wondering what happens to them after this? What is their support like? Because from where I was initially, it didn't seem like they had that much support. So I wanted to know what life was like for them after having their amputation, and what occupational therapy can do for them.
All right, so I'll attempt to answer this. Um, I would say the majority of our participants, interestingly, based on the, I'm speculating based on the duration of how long they had the amputation, they were a lot more accepting of the present state that they were in. Um, Maybe coincidentally for us as well, we did receive a lot of more positive-minded participants that a lot of them, as was mentioned in the research, a lot of them viewed the experience as um, a learning one, a growth potential. And they would have not necessarily been, not discrediting that it would have been a traumatic experience for them when it happened. But from that point to now, they would have been more accepting of it and also holding a more positive mindset towards their approach on life overall. So while sharing their stories, it didn't have much of any extreme emotional, negatively emotional experiences where we had to combat it. However, we were prepared to address that if it did happen, where we would have, in the instance where the interviews were online, we would have given them some time. And if they really were not able to continue them, we would have to reschedule the interviews while providing them with some information on social support that may be able to assist them based on that experience as well.
So we did target some of the private, sorry, you hear me now, right? So we did target some of the primary healthcare hospitals. However, the process it proved to be a little bit challenging. We did reach out several times just to get an idea what the process is like, what we needed to do, the steps to follow. Um, but it took quite some time. So by the end of the year, we were running out of time essentially. So we had to forego participants from the primary healthcare setting. Yes, that actually was a limitation to one of our studies.
All right. Well, I would answer that by saying primarily one of the things that stood out to me was the profound lack of knowledge about OT. And I think that without knowing about it, most people can't act on or access the benefits of it. So the very first thing I would say would be to really advocate for OT and enforce educating the public, the general public, about the benefits of OT and what it is. So I think one of our recommendations would have had um, informing or educating the public as well as healthcare providers of OT and its benefits and its functions. So from there, because for a lot of people, even if the general public isn't aware of it, when they have a problem, they'd go to the doctor primarily. And if the doctor doesn't recommend this, then they wouldn't really look into it themselves, in many instances. So if the doctors themselves are not aware of these services to offer or to recommend, then we also have a standstill there as well. All right, thank you.
What was surprising? Well, one of the things that was surprising was the sheer insensitivity that we have in Trinidad and Tobago, because a lot of the participants, the females in particular, they said that they needed to wear clothes that reveal their prosthetic because they had an incident where when they went to a store, they parked in the disability parking and the security comes up to them and verbally abused them, like, why are you parking in this spot? You're not disabled. So when they reviewed their prosthetic, it's like, well, you had to show clothes to show it. And that was, yeah, that was a surprise. That was a surprise. Yeah, thank you.
Added to that, sorry, adding to that question, one thing that stood out to me as well, one of the participants would have stated that there was no disability parking in the clinics. So based on that report, it was really shocking to me as well that the place where you need to go to access the healthcare isn't facilitating you getting in there, you know? So that was also really standing out to me as well. Thank you.
Thank you. I want to thank you guys so much. Thank you, Micah and Natasha, once again for your deeply and informative presentation. Your research has definitely shown a light on the physical, emotional, and social challenges that individuals face navigating life after amputation. And it does remind us of our vital role in occupational therapy and the role that it can play in reintegrating their independence as well as reintegrating them back into society. We'd also like to thank the advisors for our students, Dr. Lydia Campbell-George, for your expert guidance, as well as your support throughout their research process. At this time, we will be introducing our second presentation done by Ms. Zanik Edwards and Mrs. Anastasia Wilkinson-Gulston. Oh, and Miss Rosemary Richards. Yes, girl power. I love it. They will be coming to present to us parents of children with special needs in Trinidad and St. Lucia. Guys, please give them your ears and your attention as they come to the stage at this time.
Good day. Today we present our study, the lived experience of parents with children with special needs in Trinidad and Tobago and St. Lucia. I am Anastasia Wilkinson-Gulston, accompanied by Rosemary Richards and Zanik Edwards. Our research conducted at the University of the Southern Caribbean explores the realities of parenting within these two Caribbean contexts. Next slide, please. In this presentation, we will first introduce the study and outline the background and problems that led to our research. We will then detail the purpose of the study, our research questions, and review the literature that informs our work. Following that, we will explain our qualitative methodology, present our results and discussion, review limitations and strengths, and finally, discuss the implications for occupational therapists. We will conclude with a subjective statement and open the floor for questions. Considering the global landscape, there are approximately 240 million children with disabilities worldwide, accounting for 15% of the global population. This figure continues to grow, partly due to improved diagnostic capabilities, the aging population, and better survival rates among children with various conditions. These statistics underscore the extent and complexity of issues faced by families and caregivers across the world. At the regional level, there are 1.3 million people in the Caribbean living with disabilities. Within Trinidad and Tobago, there are 52,244 individuals, which represent 3.93% of the national population are identified as having a disability. When focusing on children, the prevalence becomes even more significant, as there are an estimate of 50,000 children in Trinidad and Tobago, or roughly 16%, that have special needs, while 8.6% of children in St. Lucia face similar challenges. These figures highlight the urgent need to understand and address the unique experiences of parents and families navigating life with children who require additional support. So before we explore the lived experiences of parents, let us clarify what was meant by the term special needs. This term relates to children who may have intellectual, emotional, behavioral, physical, or communication challenges, as well as hearing or vision impairments. Some common examples are attention deficit hyperactivity disorder, better known as ADHD, autism spectrum disorder, better known as ASD, cerebral palsy, better known as CP, and intellectual development disorder, better known as IDD. By recognizing the broad range of conditions under the special needs umbrella, it would help us appreciate the diverse and often complex requirements these children have. One of the main challenges that parents who have children with special needs are faced with is overwhelming demands of daily caregiving. Studies have shown that these parents experience higher level of stress, depressive symptoms, and poorer health outcomes compared to parents of typically developing children. In addition to physical responsibilities like assessing with mobility and providing specialized care, families are burdened with considerable financial costs, ranging from therapy sessions to necessary home modifications. Educational barriers further compound these challenges, as children with disability may face limited access to inclusive schooling. Added to which, many parents grapple with feelings of guilt and social stigma. These problems underscore the urgent need for a holistic supportive framework that addresses both the child's and the caregiver's well-being. Next slide, please. The purpose of our study is to explore and understand the lived experiences of parents raising children with special needs in these regions. By focusing on daily care routines, educational barriers, and coping mechanisms, our qualitative approach reveals not only the challenges such as poor school infrastructure and social stigma, but also rewarding moments that affirm parental resilience and hope. So our research questions as follow. What are the barriers parents experience regarding their child's school attendance? Number 2, what coping strategies do these parents employ? And number 3, what characteristics contribute to caregiver burden? The significance of this study was to understand and identify the key factors that impact the lives of parents raising children with special needs. By gaining insight into their daily challenges, the study contributes valuable information that can be used to guide occupational therapy-driven interventions. Additionally, the study promotes advocacy and policy reform by highlighting gaps in existing support systems, while fostering community support and awareness that encourages the sharing of available resources and future interdisciplinary collaboration. I will now turn the presentation over to Rosemary, who will present on our literature review.
Thank you very much, Anastasia. Now we move on to our literature review. This is the information we gathered prior to our research. When considering barriers, parents spoke on experiences in the school system affecting their child with special needs. Parents mentioned that teachers' inadequacy in special needs resulted in limited classroom resources, such as assistive technology to aid in functionality. Studies showed that discrimination faced in the classroom, such as mockery and social exclusion, caused parents to keep their child home, further hindering academic growth. Another study highlighted that poor infrastructure of institutional buildings caused barriers for those with physical challenges. In these studies, parents found different ways to cope with their challenges. Some used a positive approach to manage. These were peer support, faith, and seeking therapy. Others used a maladaptive approach, which did not aid in addressing these issues, but actively avoided the situation, internalizing their stress, which led to depression and increase in pain from poor psychological adjustments. Another study highlighted a befriending scheme, which is a planned social interaction to provide friendship to those who are vulnerable. Psychological and physical strain were major factors to caregiver burden. A study noted that the persistent care for children with disability is a demanding role resulting in depression, insomnia, muscle ache and pain, guilt, and anxiety. Now we move on to our methodology. Our study was a qualitative phenomenological study that recruited participants using purposive and snowball sampling. The image on the right was the flyer used to recruit some participants via email and some persons from clinics. The inclusion criteria for participants of the study were parents living in Trinidad and Tobago or St. Lucia with children diagnosed with either a physical or cognitive disability. Their child must require 2 or more additional hours of dependent care compared to their same age peers. The child's age must range from 4 to 18 years old. Next slide. We gathered 16 participants from our recruitment, 11 from Trinidad and Tobago, and 5 from St. Lucia, and conducted semi-structured interviews via Zoom. Our interviews were audio recorded and transcribed using TurboScribe. Our data were analyzed using thematic analysis. The data were collected from August to October 2025. 2024, my bad, sorry. In terms of ethical concerns, our study was approved by the University of the Southern Caribbean's Institutional Review Board. A consent form was sent to participants with details of the research, and each of them gave verbal consent. Participants' confidentiality has been maintained throughout this process. Persons were respected and given the right to withdraw from the study at any point. They were gifted either a Rituals or Starbucks gift card of choice with the value of 50 Trinidad and Tobago dollars or 20 Eastern Caribbean dollars as a thank you for their voluntary participation. I now pass you on to my group member, Zinique, for the results.
Okay, so to the right side of our screen, we can see that 6 out of 16 of our participants, the majority of caregivers interviewed were mothers with only one father in the mix. And to the left of our screen, the pie graph, we can see that majority of our participants were employed with only one person unemployed. Here we can see evident that our most common diagnosis represented with 10 participants with this diagnosis was the autism spectrum disorder, and with cerebral palsy having the second most frequent diagnosis. Next slide, please. So now we're going to explore our results. When answering the question, what are the barriers parents of children with special needs experience about their child's participation in school, we were able to identify 3 different themes which contributed to the barriers that parents face. For inability to attend school, parents expressed frustration over long waiting lists for special schools, and some highlighted the lack of accessibility for wheelchair users. One parent expressed, the school lacks resources to cater to his mobility needs. Because he's in a wheelchair, he is unable to transition into a higher classroom, which is located upstairs. When exploring the theme, school being ill-equipped to meet parents' expectations, some parents note that the school lacked necessary support systems to assist children. One parent stated, the school aide assigned to her lacks training or interest in working with her. Under the theme stigma, we looked at social attitudes towards children with special needs. Some families felt that other families prefer schools without children who display challenging behaviors. One parent stated, most Trini parents don't want their children who are typical in a school with no child with abnormal behaviors. They're not even informed enough to call it autism. Instead, they look down and ask, why is this child behaving so? Next slide, please. As we explore the results under the research question, what are the coping strategies of parents of children with special needs? We were able to identify 2 themes. Parents were able to share positive experiences encountered with their child with special needs. One parent stated, he is blind, but rides a bike and enjoys horseback riding. It is incredible to see him experience life without limitations. A few parents spoke on the importance of social support systems. One parent expressed, I thank God I have a partner, my husband. We take turns giving each other breaks when things get overwhelming. Next slide, please. When answering the question, what are the characteristics contributing to caregiver burden, we were able to identify 3 themes. So this emphasized the multifaceted challenges that caregivers face. When we look at resources, when we look at resource strain, parents experience difficulties in accessing affordable services. One parent expressed, Clinic A offers affordable services and tries to accommodate all parents regardless of financial situations. However, they stopped seeing my child when he turned 5, as they don't offer services to children after. After that, he hasn't had consistent therapy since he was 5 because St. Lucia lacks therapists. This child is now 14 years. Another theme identified was caregiving challenges, where parents showcase the demanding nature of caregiving as they illustrate the additional time and effort required for daily tasks. One parent stated, sometimes I have to feed her to speed up the process because she takes too long to eat. When exploring mental and physical exhaustion, one parent divulged, I don't always want to be strong. I often want to break down and have someone take care of me for instead of me taking care of everyone. So now I will pass you on to my colleague Rosemary, who will delve into the discussion.
Thank you. Thank you very much, Sanique. And now we move on to the discussion. We gathered research that was consistent with our results from the themes we curated. I will highlight 4 of our 8 themes. First, academic barriers. A regional study on the Dutch islands highlighted academic barriers to inclusivity. Parents shared that the lack of specialized, disability-specific training in teachers resulted in a barrier to successful transition and inclusivity within the classroom. This hindered learning, especially for those with autism spectrum disorder and developmental disability. Satisfactory special education schools had a long waiting list, making it difficult to find a suitable school for their child. In terms of stigma, a Jordanian study showed the consistency with our results as mothers shared the heartbreaking discrimination faced within their families. Family members either hid or refused to acknowledge their relations to those with special needs. They also face exclusion in public places, such as play parks, where other children scolded or showed disgust towards their child. Next slide, please. Additional studies showed consistency with our results in terms of positive experiences. In a systematic review, parents experienced emotional satisfaction and a sense of connectedness with their child with special needs. Others felt empowered while they were able to meet their child's daily needs. They stated that these experiences made them more resilient in life's challenges. Financial constraints were reported in studies similar to ours. A Ghanaian study had participants reported becoming a single income household by force as their child required high levels of consistent attention. Another participant stated that their child's specific meal preferences were causing them an additional grocery expense and a waste of resources as they may refuse to eat their particular meals occasionally. According to an Aboriginal Australian study, a participant mentioned working overtime to pay off their credit card debt for hospital bills, therapeutic services, and special education. I now pass you on to Sinique.
Thank you. So despite the insightful findings of this study, it is important that we acknowledge the limitations. Firstly, the small sample size did not represent the broader community of caregivers, limiting the generalizability of the findings. Additionally, snowball sampling resulted in the lack of diversity to capture a wide range of experiences. For example, 94% of participants were mothers. Also, more than 60% of the diagnosis represented was autism spectrum disorder. When considering the differences between islands, the study's findings were shaped by the unique cultural, social, and economic context, which may limit their applicability to other Caribbean islands with different circumstances. Going over to strengths, the study explores and brings attention to the day-to-day experience that parents face. Parents' individual perspectives shared provided personal insights into the challenges they face. Transparency was reinforced through the use of direct quotes, as it offered a balanced view by acknowledging both positive and negative aspects of parenting. The distinct needs between the two islands were emphasized and offered valuable information for policymakers to tailor their decisions and create more effective support systems. Next slide, please. Implications. This study shed light into several important implications for improving support systems for parents. Firstly, the need for comprehensive policy reforms required the collaboration of key stakeholders, including ministries of education, health, finance, and social development. These collaborations between the ministries could establish a national framework to deploy occupational therapists in schools. This approach mirrors international practices such as the US model under the Individuals with Disabilities Education Act, where school-based occupational therapists are a mandated service. This integration not only supports children's development, but also offers financial benefits by reducing the need for parents to pay for private therapy services. Governments and NGOs should develop sustainable financial assistance programs, including therapy subsidies, tax incentives, and tuition supports. These measures would help expand access to essential services like occupational therapy, which play a crucial role in providing holistic care. I now pass you on to Anastasia.
So in conclusion, the key challenges for us, in conclusion, the key challenges for us as outsiders is deeper understanding of the realities that parents of children with special needs experience. This insight is crucial for informing future policies, support programs, and strategies to better assist caregivers and create a more inclusive environment for both children and their families. And finally, the study emphasized the urgent need for improved support system, inclusive education, and greater awareness of caregivers' needs. I will now pass you on to Rosemary for the subjective statement.
Thank you, Anastasia. And finally, we move on to the subjectivity statement. We as occupational therapy students and a special education teacher, our biases were being overly empathetic towards the participants. Due to existing relations, there was a familiarity with participants, which would have influenced their responses and data interpretation. To mitigate this issue, data was peer-reviewed. Now, these are our references. And in closing, we would like to thank God first for helping us with this research, giving us the health and strength to complete everything that was needed. We would like to thank our lecturer, Dr. Seeley, and our advisor, Dr. Cokerbolt, for their endless support. We would like to thank the research participants' family for volunteering their time to assist us in completing our research project. And finally, we would like to thank our members of staff for the Occupational Therapy Department and Cohort 5. Do we have any questions?
Great job, guys. So I have a question from Dr. Seeley, actually. And she wants to know if you guys had a chance to redo your project, what would you do differently?
So one of the things we would do is try to get different diagnoses, as we had a high number of children with autism. So that's something definitely we would want to change to get more balance.
And how do you think you can do that, like, to get that balance? Where do you think you need to go? Do you have any idea what you might be able to do to get that balance? Since now that you got many persons with autism, do you think there's some way you can possibly get different diagnoses, go to get different diagnoses?
I can answer. Thank you for your question. I would say, okay, so for our results was also, we had some time constraints because of when we started gathering our participants, schools were closed and it was vacation time. So I think with redoing it, we will ensure that we send out flyers and recruit participants during the school period, so we will get a better response and we'll be able to access more special education schools where we'll have a higher chance of getting a wider variety of diagnoses.
Okay.
Just wanted to add to what Anastasia said, not only getting higher diagnosis, but also a greater difference with the caregivers. So we got parents, we got moms, and majority of everyone was employed. Yeah. So I think it would be good to include for future research having parents who are unemployed, because there is a wide variety of parents who are parents of children with special needs who are unemployed, and the plight that their experience will be very different from some of the experiences we shared today.
Okay, because that was my other question. You think there will be other experiences that you get different from unemployed to employed parents?
Yeah, I think it will be hard on them. Yeah.
Another question.
Question. Firstly, wonderful presentation, ladies. My question has to do with the fact that it was both Trinidad and Tobago and St. Lucia that you all looked at. I believe you all would have highlighted the similarities in the experiences of the parents. Did you all notice any differences between the lived experiences of parents between Trinidad and Tobago and then St. Lucia?
Right. Okay, so one of the main differences highlighted is the availability of therapists in St. Lucia. So currently, St. Lucia has an early intervention clinic, and they don't see children after 5. So you find that children within the special schools, ages from 5 and beyond, there is no therapeutic intervention. So that was one of the major differences between the two islands.
Okay, thank you.
Okay, well, I guess I have a question. But coming out of St. Lucia, is there anything in your project that you see that you can implement in St. Lucia so that they can advocate or assist students who are special needs as well as their parents who, parents of special needs students?
Yeah, we can advocate for therapists in school because currently the staffing structure within Ministry of Education, St. Lucia, there are no positions for therapists of any kind, right? So I know some of the teachers, being a teacher myself, I know the whole party is struggling. So, and I can feel their struggle, I know their struggle. So I know that support is needed to help them deal with some of the challenging behaviors that they get in the classroom.
I just want to ask you, some of these special children that are there, they are there because of some cultural practices that the people have. So, and related to the genetics, did you find any particular practices culturally that can contribute towards these special children? For example, there are people who have closed marriages in the closed families, and that can result in some of these children. So if you did stumble upon something like that, you can share with us. Thank you.
Hi, thank you for your question. Just to confirm, you're asking if we stumble upon any participants who are close-minded to therapeutic interventions? Yeah.
So there are closed inbreeding. They marry within their family members, and that can contribute towards that. Yeah, that's a genetic, of course. So that's what I'm asking. But if you did come across some cultural practice like that.
Okay, thank you. No, we did not come across any of those cases in our study. Thank you.
Right. Thank you for your presentation. My question is similar to what Dr. Chan was asking, but was there any cultural practices, beliefs and practices that would have contributed to the barriers for treatment, or was a burden to caregivers because you were identifying a number of financial, social, and other barriers? Did you find any cultural beliefs and practices that was a barrier?
Thank you for your question. I would, as we will answer, some cultural practices, I would say a lot of stigma. So some parents either were ashamed to go to therapy or ashamed to get a diagnosis because they did not want others to know something was wrong with their child. Sometimes it was internalized. Parents did not want to think that something was specifically wrong with their child or their child was different. So yes, there was a huge stigma that was found within our study. So that was the main thing, internalized stigma as well as social stigma.
Very good presentation. I know you're thinking, oh, that's it for questions, but one last, I'm going to make it very easy. But I noticed you give gift cards, and I mean, everybody wants a gift card to participate in the research. What do you think you may have done, could have done differently to increase the amount of responses or participants? Because you had like 11 in one case and 5, but I think gift card would have encouraged persons. So what do you think, despite having that, would have contributed to your low participation rate? Maybe something in your recruitment you could have done differently, you think?
So our sample size number was specifically crafted by us with the guidance of our lecturer and our advisor. So they wanted a small sample size considering it's a qualitative research and that we would have to, the whole process of going through the information gathered through the interviews. Yeah.
But based on the type of qualitative study, there's a recommended sample size. So even if that is the case, in one case you had 5 participants in one country and 11. So those were selected for a particular purpose as well?
Can you repeat the question? Sorry.
Okay, so I'll just make a comment to make it easier. So like in a phenomenological study, it would be recommended about 10 to 25 participants. So on that basis, so when you're justifying, you have to support it to say this study recommends that, this particular sample size is ideal. But in this case, you had 5. So that's just my comment. So that would just come as a comment. Congratulations. Well done.
If I may be permitted, I have one recommendation for both the presentations. Since both the presentations were qualitative, and you did well with your thematic analysis and all, but when it comes to presentation of demographics, just avoid using statistics. That will not make sense, okay? It was 5 in one and 11 or 12 in another. I would recommend put a table, okay? And I can share that with you. So a table of demographic will make more sense than putting percentages because we will be struggling to capture what the percentages was talking about because it's a qualitative study. So I'll recommend a table with all the demographics and number that can be reported in the demographics. So gender, male, female, how many males, how many females, ethnicity, different ethnic groups, how many in each category. So numbers that way. So a table will be very useful. So you can include that, remove the statistics, okay? And include a table in your thesis or whenever you're presenting a qualitative study, okay? Thank you.
Thank you.
Thank you, ladies, so much. Once again, thank you, Ms. Edwards, Ms. Richards, and Mrs. Gulston for such a heartfelt and compelling presentation. Guys, you have given us a window into the emotional and financial, as well as the societal challenges that parents do face, as well as it's powerfully emphasized the importance and the support that is needed to help these parents along the way. We'd like to thank your advisor, Dr. Patricia Coker-Bolt. Thank you very much. Yes, for her mentorship as well as her guidance. And we'd like to also, as well, once again, thank Dr. Viv, as well as the support that we were given to our students from the School of Graduate Studies. At this time, all right, so as we draw near to the end of our program, I would like to invite Dr. Seeley, our adjunct professor, to share closing remarks.
Hi, well, good morning, everyone. I guess it's afternoon on your end. It's right 1 minute after the hour. It is my pleasure to be here. And since all protocols have been observed and acknowledged, I just want to do a quick wrap up. So I thank everyone who would have come out this morning to hear our students, whether it was family, friends, etc. I express my profound gratitude. I am especially proud of the students and the work that they would have done, proud of the efforts that they took to collect primary data and to be able to do their presentations this morning. There's a definition of research that says it is formalized curiosity. It is poking and prying with a purpose. So I am thankful that they have been able to establish their curiosity on particular topics and poke and pry and get to the point that they could get these results. My wish for them at this time is that they would remain curious and that they would continue to share their findings with wider audiences and with wider circles so that they can get the research out there. I have to say that in today's culture, with the surge of AI, it is changing curiosity. It's also changing the ability to write and to understand. And I am hopeful that even with all of that, they would continue doing so. I am proud of the students, what they have done this morning. I'm proud of the work they have done over the past 2 years. They have worked on these projects for approximately 2 years to get to this point. And at this stage, we know that this has created the opportunity for advocacy, using their voices to speak for those who may not be able to do so for themselves. I trust that the participants who told them their stories and trusted them with their stories will see the benefit of the work that they would have done with their engagement and with their advocacy for the students. So to each student, Zanik, Anastasia, Rosemary, Micah, and Natasha, congratulations on a job well done. I'm proud of you and I'm looking forward to seeing you sharing your findings in larger circles and with more persons so that we can hear about the work that you would have done and that you would continue flying the name of the university in the circles that you would find yourselves in. So once again, have a wonderful afternoon. You can relax, you can breathe, you can feel the stress leave you now, and just enjoy the rest of the afternoon. I thank you.
For those inspiring words. At this time, we will invite Ms. Edwards, our third-year MSOT student, to deliver our vote of thanks.
Thank you. Okay. It was John F. Kennedy who said, we must find time to stop and thank the people who make differences in our lives. So allow me the honor of doing just that today. To our esteemed president, Dr. Wilson, who wanted to be here in person but was not able to, our provost, Dr. Len Archer, and our dedicated professor, Dr. Seeley, we are grateful for your continuous commitment to our excellence in education. To Dr. Lewis, thank you for sharing your research with us on this community of people who are often overlooked. Your presentation truly set the tone for today's event. From one researcher to the next, I think we were able to connect with you on some of the biases that you shared. You mentioned that you guys are not there yet, but after hearing some of the programs you have in place, I would say that you're very much on your way there. To our director, Dr. Reef, and our lecturer, Mrs. Shakila John Marshall, thank you for pulling together such a wonderful event and for your continued guidance throughout this program. To our incredible advisors, Dr. Patricia Cocabolt and Dr. Campbell George, thank you for your unwavering guidance, your constructive feedback, and your consistent support throughout this journey. Your mentorship has been instrumental in bringing our dissertations to life and in shaping us into the professionals we are becoming. To our gracious masters of ceremony, Mrs. Burrows, Thank you for keeping the program flowing so smoothly. To the young lady who blessed us with such a moving musical rendition, thank you for adding such a beautiful touch to this special occasion. To the members of Cohort 6, to whom we now gracefully pass the baton on to, thank you for showing up and assisting with the execution of today's events. It wasn't long ago that we were standing exactly where you are right now. If there is one piece of advice I can offer, it is learn how to truly support one another. As Grace Keller said, alone we can do so little, but together we can do so much. I wouldn't be standing here today without the unwavering support of my classmates. To the family and friends of Cohort 5, thank you for being our rock for this process, for the encouragement and the sacrifices you have made behind the scenes. And finally, to the heart of today, my colleagues, the future occupational therapists of USC 2025, Cohort 5. We did it. Just a simple thank you, though only 2 words, is a mighty powerful prayer. It carries with it the weight of sleepless nights, our shared struggles, and unforgettable triumphs. It is with a heart full of gratitude that I extend my sincerest thanks on this momentous occasion, which also marks the successful completion of our research day. Let us move forward with purpose, pride, and passion, knowing that the best is yet to come. Thank you all and congratulations to us all. Thank you.
And finally, we close with a prayer from Ms. Shakila John Marshall, our MSOT Academic Fieldwork Coordinator.
All right, let us all assume a position of reverence. Our merciful and heavenly Father, thank you so much for bringing us to the end of such a successful event, dear God, where our students were able to display what they would have been researching over the past few years, dear God. Lord, as we're about to depart from this place, I ask that you would give us traveling mercies, be with each family represented here, grant them your protection, dear God, as they go about their business today. This is my prayer in Jesus' name, amen.
All right. Well, thank you, everyone. Thank you so much for coming out today and joining us in this year's MSOT Scholar Day. You can give yourself a round of applause for all of the hard work that the students have presented to us today. We encourage you to take this time to review the insightful poster presentations on display, and may the knowledge that has been shared with you today inspire and continue to grow in excellence in the field of occupational therapy. Have a wonderful day. Take care.